Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I am with my good friend Pac. How are you doing today?
Howdy. Thank you for inviting me to this podcast, Dennis. We've known each other for many years now. As you know, I'm over in Europe and you're in the States, but I had the chance of visiting you in Bragg, so that was great.
No, I had a great time. So first, I'd like to say, thank you very much to some of our sponsors. We have Delta Development, we have North American Rescue, we have Special Operations Technologies, and also thank you to all my Patreon members. I couldn't be talking to Pac without you guys, so I really appreciate it. But today, the reason why I asked Pac to come on the podcast is he's got an enormous amount of experience with ketamine and specifically S-ketamine. So Pac, would you just do a real quick introduction of yourself?
Sure. I'm an anesthetist by trade, educated way back in the 80s. I was a senior consultant at university for many years, and then decided to become a military medical officer at the age of 52. And that was great. It was really a change from the hospital world. And I was a military anesthetist for a number of years, working abroad in many different operations, working with the Americans, Canadians, French, Germans. And then I became the MEDAD for the Danish Special Forces, Special Operations Forces, in 2010, and worked with them for 6 or 7 years. During that time, we developed the European NSOCOM, NATO SOCOM course. I was helping the ISTC, which is the Special Training Center in Germany, in Fullendorf, constructing their ISTC and SOCOM course, which was more or less the same as the Nordic. And then we've been running refresher courses for all these NSOCOMs that we've educated. I think we've educated both of our centers 300 the last 10 years.
Nice.
So ketamine I've used both as a doctor in hospitals and ketamine as a military anesthetist, both doing MERT work, medical emergency response team work, but also using it in the military hospitals. And there's no doubt about it, I'm a great fan of ketamine.
Perfect. Well, you're the perfect guy for it. So S-ketamine, whenever I'm training with any of the Europeans, I don't really get to use S-ketamine very much. We don't have that here in the States. And usually the way it's described by my European brethren is like magic sauce and nothing ever bad happens to it. And it's vastly better than the stuff that I have here. So what is this magic elixir that you guys use over there?
I hate contradicting my European brethren over here, but Dennis, you are completely right having this sarcastic tone, because when ketamine was made in 1962 and developed and synthesized, and the Americans actually started using it in battlefield analgesia back in Vietnam days, it consisted of an R-ketamine and S-ketamine. It was a hybrid. And all of a sudden, some clever guys back in around 2000 and I don't quite remember the year, but they decided that S-ketamine would probably be the drug to develop instead of R-ketamine or the hybrid, suggesting that the S-ketamine would have a better analgesic profile and maybe be less hallucinogenic in mid-dose. But it turns out that when you use S-ketamine, you just use the suggested doses is just half the old ketamine. So that means, okay, it's more potent, but so if the effect is the same and the adverse effects are the same, it doesn't really matter that you give half dose because you mix it in the same amount of cc's, right?
Yeah.
So in S-ketamine, I think you have in a dose of 10 milligrams per mil. That's the basic S-ketamine. Ketalar, in old days, you had 20 milligrams per cc, right? So that's the same amount. You have a more potent drug in the same amount of fluid. So what you're doing is you're injecting fluid, right?
Yeah.
And what we are interested in is the effect. We are interested in onset time, duration, and not so much potency. It doesn't really matter. Fentanyl is more potent than morphine, right?
Yeah.
So, but you just give fewer milligrams or fewer micrograms of fentanyl to get the same effect.
Yep.
Same thing with ketamine. Ketalar was the old R and S mixture, and S-ketamine is the newer one. And it's probably more expensive too, milligram per milligram. That's usually how it is. So, but what we are interested in is onset. We are interested in effects. We're interested in complications, adverse effects, side effects. And they're exactly the same. Exactly the same. There are some small academic things. For example, if you're using a mid-dose of S-ketamine, maybe you will have less hallucinogenic effect and fewer adverse psychological events. Right. But again, if you have a patient with one of these, then the rules and the suggestions all say, give them a bit of Versed and then it's over. Okay, then we can talk about this. But getting back to when I started using Ketalar, the mixture, it was in austere environments up in Pakistan, in northern India, or northern Pakistan, all the way up by the Khyber Pass. We were treating Afghan war wounded who were being massacred by the Russians at the time in 1985, 86. And we had hundreds and hundreds of fragmentation wounds, shrapnel wounds. And they all needed small surgeries. They needed washouts. And we only had 2 surgeons and 1 anesthetist and some Pakistani trainee anesthetists. So what we did was that we lined them up in the morning, 6 patients at a time, wham, 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 in with IVs. We had a little bit of atropine ready on each table. And then we got the anesthetic nurses, the medics trained to give slow pushes of ketamine until we had the onset. And that was nystagmus we were looking for. The so-called 1,000-yard stare and nystagmus. When it was there, they were trained to ensure free airways. They were also trained not to give the IV push too quickly, because we all know with ketamine, if you really bung it in fast, then you're going to have problems, a slight respiratory depression for some minutes, and possible bradycardia. And that's why we always had the atropine ready.
How much atropine would you push?
You push 1 milligram at a time. You wouldn't push anything. You don't need that really, because it's a transient period until the peak level of ketamine just falls a little bit, and then everything turns out normal. But you have to be aware of it, of course. And it's especially elderly patients and kids. So we're talking children under 3 months, 6 months old. There you have to be especially careful using ketamine. But everyone else, you put in an IV line, you put on your SAT monitor. We didn't have SAT monitors. We didn't even have blood pressure cuffs. We measured the pulse, right? And then you just inject the ketamine slowly but surely. At that time, it was 1 milligram per mil. Everyone can remember that. And if you ever wanted to continue, then you would either bump him up with a half dose every 15 minutes, or you would make a drip where you ran 1 milligram per kilo per minute.
Yeah.
That was so easy to remember. Everyone could do that. Atropine was 1 milligram, right? And another thing with atropine, just get back to side effects, some patients do hypersalivate. And of course, when we're talking about free airways, maybe it's a good idea that these patients also receive some atropine that dry out the mouth, right?
Yep. Especially if you're trying to sedate them for, like you were talking about, for surgery.
Yeah, exactly.
Yep.
So what I was talking about is the deeper sedation for surgery, not pain treatment yet, because I'll get back to that in a second when we talk about battlefield analgesia. So then we did that. These small washouts, they lasted around half an hour, 40 minutes, depending on the severity. Washed them out. I did that. The surgeons did that. The nurses did it, depending on how severe it was. And then 10 minutes before we were finished, we gave them a little bit of morphine. We gave them around 2.5 to 5 milligrams of morphine IV. And that was to combat the possible emergence phenomena. Most of our patients were Afghanis, and we didn't really see any emergence phenomena with these patients. It's well described, up to 12-16% in a population in England, for example, where they did a study. 12 to 16% get some kind of bad dreams or hallucinations, short term. The Afghanis didn't get that, so we were not using very much Versed at all, but we had it. And if we had patients with severe emergence problems, we would have given them 1 to 2 milligrams of Versed IV slow push.
Nice. Just a quick question about that, Pac. So the differences in populations, like Afghanistan, I remember them being very, very stoic people compared to Americans, compared to some of the Europeans. Other countries in the world are very similar. In fact, in that they don't expect much healthcare, so they just suck it up. Do you think that has something to do with hallucinations, that maybe they have them, but they don't react to it?
I think it's quite possible. That is what I've always been thinking. Yeah.
Okay.
But what we have to do, we have to react. Our duty is to react and treat this and help this. Yes. And of course, if they don't show anything, then we can't really do anything, right?
Right. Yep.
No, that was the Afghanis. They handled that very, very well, and there was a big culture difference.
Yes.
I think actually they did a study. We could probably find it somewhere. I think it was 500 patients from England and 500 patients from Pakistan, where they looked at emergence phenomena after ketamine, and there was a major difference. Using the objective criteria that they were using for that study. So, but this is sedation, and when you use S-ketamine, then it's half dose, right? As I was saying before. Then it's 0.5 milligram per kilo induction dose, just as a rule of thumb. You induce the patient, and then you look for the battlefield stare, and then the nystagmus. And if he doesn't really reach that stage, then you bump him half dose again. As we know with S-ketamine and normal ketamine, there's a very, very high tolerance for side effects or overdosing. You can hardly overdose. With the amount of ketamine we have in our combat bags, you will not probably make big problems, right? There were even some Americans some years ago talking about giving 300 to 400 milligrams of ketamine as analgesia on the battlefield. Oh, yeah. Okay. That was 6 or 7 years ago. It'll really work. And you've got a very sedated patient for your helicopter transport, right?
Yeah.
So, but that was one of the suggestions, but we don't do that anymore. Battlefield analgesia. Well, that's very interesting because back in 2009, I was working in the British Field Hospital in Camp Bastion as an anesthetist. flying with the Royal Air Force, doing medical emergency response team work, going out with the helicopters, picking them up. We were co-located with Dustorf, which was also in Camp Bastion, and they were using morphine as battlefield analgesia. So what was more natural? We were using ketamine, they were using morphine. We had whole blood. They didn't have any blood at all. So we had really some interesting weekly discussions. Unfortunately, one of my junior medical officers did a study, 25 patients from each group, looking at pre-hospital, hospital, emergency room, adverse effects, whatever, pain scores. And there was no doubt about it, ketamine was effective. And many other studies, I think there are around 25, 30 proper RCT, randomly controlled trials now on ketamine and battlefield, shows that ketamine is superior to morphine. There's no doubt about it.
Yeah, it definitely works very well.
Our problem with ketamine is that you have a quick onset IV, you have a duration that's quite short, 20 to 30 minutes. And that's our problem when we're talking analgesia.
Yep.
So what we teach in Europe here is that we very quickly go over to morphine. I think you do the same thing in parochial
or
care.
fentanyl. Yeah. So I like morphine. I've used hydromorphone also. But I'm just using it so that once everything is kind of settled and the patient is relatively stable, and they can handle something like that, start with small bumps of a longer acting agent, just so I can free up my hands, free up my mind about take care of probably other patients.
Yeah. Problem with using ketamine, for example, ketamine mixed with propofol has been suggested also. But listen, now you're mixing two drugs. You've got low supplies of your drips, of your fluids. Why not just use the easiest stuff, that's morphine, and learn to use it. Learn to use it properly. The rule of thumb with morphine, as you know, is you can give it every 4 hours and then you can bump it up once in a while. That is so much easier if the analgesia works, right? But you're going to have patients with severe pain where morphine just doesn't work.
Yep.
And that brings me also to something else we can always talk about.
Sure.
You've got a great guy in the States called Chester Buckenmeyer, who's the big regional anesthetist doing regional analgesia. Yeah. Have you heard of him? Yeah.
No.
He developed the whole ultrasound regional anesthesia. He wrote a book. Actually, you've got it on your homepage, on your website, called Military Regional Anesthesia and Analgesia.
Yep,
He's the author, And Chester, I worked together with him in 2009 in Bastion. And he's a great guy. And we talked a lot about regional anesthesia. I was doing a lot of regional anesthesia too, and but using nerve stimulators instead of ultrasound. Yeah. And so he taught me a whole lot about this ultrasound stuff. But the thing is, combining regional anesthesia with IV analgesia, that's the way forward when we're talking austere environments. Really.
Yes.
I'd like to just mention that here also.
Yeah, absolutely. Even like guys, they want the easy button answer. Ketamine will do that, more or less. But when you're talking long-term care, a regional block may or may not be able to take care of the entire problem. You have shrapnel injuries across the body. You're probably not going to block everything. But even if you can just whittle down some of the things that are actually hurting the patient, whether that be, an extremity block of some kind or rib blocks, at least you're knocking that down, and you're kind of, at least in my mind, you're taking that pain out of the equation for, X number of hours. And you're ultimately going to use less narcotics of whatever kind.
The worst pain I've experienced with soldiers are femur fractures, either open or closed femur fractures. The major trauma, the amputees, the quadruple or the double, or they usually don't have that much pain. Usually they're also quite snowed under, ventilated, and whatever. But if we're talking about this pain from smaller trauma, the femur fractures are absolutely probably the worst. Yeah. And even though you put in a femoral block, it takes 30 seconds, and he's pain-free for maybe 4 or 5 hours. I remember a big American guy. He was probably 110 kilos, brought in, screaming on pain, thrashing around. He had received some ketamine on board the helicopter also, and not enough ketamine. So he was in this mid-stage. Yeah. If 4 people were holding him down, and there was no doubt he had an open femur fracture. Wham bam, took 20 seconds to put in this femur block, and then pain-free, right? And then the ketamine started working. There were a bit of psychological events still because of the ketamine, but that we handled with a little bit of Versed, and changed the situation completely. And you can easily imagine one of your guys in a small room in some shithole, screaming on pain, how that is going to affect the patrol or the team, right? So you want him pain treated, Yeah.
You need to, for a bunch of reasons, you need to stop this situation. And one, guys probably not having as much experience as they should. And 2, because of that lack of experience, they don't have a plan. So they're just going in with theoretical knowledge, book knowledge. This one guy told me this, some other guy told me that. Well, he's a doc, he's a nurse, he's a whatever. Yeah. And they don't really know what to do with the information because they've never actually done it,
I mean, Dennis, you're completely correct. And this is one of the big training scars we've got. When we are doing our training, they just bung in some salt water and they say, I'm giving 20 milligrams of S-ketamine or 50 milligrams of ketamine. And they look at the instructor and say, is that okay? And the instructor jumps into it in the deep end of the pool and says, yeah, that sounds good, right?
Yeah, because he doesn't have experience either.
They don't get any training out of it. So one of the good suggestions I've heard is that utilize your vets. I think it was you mentioning it. Yeah. I'm quite sure that a lot of vets are using ketamine or something like ketamine, where at least our medics could get hands-on delivering a drug and looking at the effects. And this is what you're talking about, right? Yeah. Didactically, they know that they get the battlefield stare and the 1,000-yard stare and the nystagmus, but they've probably never even seen nystagmus, right?
Right.
And what's a battlefield stare? And they've never seen that. I mean, you can easily, just seeing it 3 times, you'll remember it the rest of your life, right?
Yes.
This is our problem. This is our problem with training,
Yeah. And I think, obviously if you're doing some kind of veterinary work, hopefully the vet will allow you to use the drugs, the narcotics that you would normally use. Like, hey, I use ketamine a lot. It will work. Like, ketamine's a kind of a ubiquitous vet drug for a long time, and it's just ketamine coming back into human population again. But it'll work. I think the best thing about it is the dosings don't match human dosings. But the key training point is it doesn't matter. You have to dose it for that patient. And people forget that other people are just different because of a bunch of reasons, like just genetics, like what they ate that day, whatever it is different. And you have to be comfortable adapting to the situation to get the effect you want.
So I think same with all drugs. Yeah. The same with all drugs, right? You give insulin. What do? You measure blood sugar, right?
Yep.
You give a pain treatment. What you should do is measure your VAS score before and after. You should do that, and you should document it. The same with if you're going to go into deep sedation with ketamine, you decide on a dose. As you say, you've got to have a plan. Where do I want to go with this dose? You've got to say, I want 1,000-yard stare in nystagmus, and I'm prepared to bump it up if he doesn't get there, right? You have to have a measurement. You have to have some objective way of deciding what to do. And this is what we have to teach them, right? Exactly. And then the next thing is, then you've snowed them. They're down. You say to the surgeon or whoever's going to do the skill, you can do the chest tube, start the chest tube. Then he does the small incision, and then the patient starts verbalizing or moving his arm. You can see that with ketamine. Also with S-ketamine, there's no difference. And you've got to prepare the guys that this can happen. And you've got to be prepared yourself. Because what am I going to do? Am I going to panic now? Is the patient waking up? No, look at the eyes. He's still got the 1,000-yard stare. He's just verbalizing. Yep. Okay, if you don't like listening to all this verbalization, maybe you can give him a little bit more, or you can give him some Versed, which would also help a little bit. But you have to have a plan, right? Yes. And this is what you're talking about. And when they don't have experience, then they're going to have problems.
Yep, exactly. Yeah. So I think sedation with ketamine, super easy. If you have a really panicked situation, a great big bump of ketamine, slowly, hopefully, will settle it. But where I think is a lot harder is just analgesia. When you don't want to snow him, you want to just calm him down some, take care of the pain, understand he's going to keep talking, he's going to keep moving around, but you have to have a way to assess, did you actually take care of the pain, or did you miss your mark and now he's in the middle of that curve, How, as an anesthetist, as somebody who's worked in austere situations, how did you kind of work that with ketamine?
Well, when we talk about analgesia, you have to decide, you're going to use IM or you're going to use IV, first of all. Do I have an IV in, or is this so acute, or there's such a big problem, I have to snow him, I have to give him pain treatment before I give him the IV. That's the first step, right? Okay. You have to have, of course, sure.
Yeah, let's pretend that at the moment you don't have an IV yet.
Right. Then the magic sauce you're talking about, you can give it in any manner you want. You can give it intranasally. You can give it IM, subcutaneously. You can give it orally, and you can give it rectally. Okay. The thing you have to remember is there are different bioavailabilities. So when you give something IM instead of IV, when we're talking S-ketamine or ketamine, you have to double or triple or quadruple the dose. If you look in literature, there are different suggestions. The Marine Corps in the States have got a training manual for their TCCC where they talk ketamine. And I noticed they write, if you give, you have to give 6 times as much IM than you do IV. That's not what I learned, and that's not my experience, because it's not. And we're talking about pain treatment, and if you give a 6-fold dose, you're going to snow him too much. You're going to go up into what we call middle dose, and that's where you get the adverse psychological events. We want to have him pain treated and more or less calm. So what I would suggest is a double dose. Of ketamine. But this is my experience, it's my opinion. If you give it rectally, for example, children, you don't want to give, don't want to jab them, you don't want to put an IV in them, and it's just a short thing, you want to sedate them a little bit, then you can use 4 times the dose rectally. You take a suction catheter, cut it off, and put it on the syringe, and then place it anally and then inject.
Okay.
Then it takes, onset time is a bit slower, of course, but if onset time IV is 1 minute, then we're talking about onset times of maybe 10 minutes when it's rectally, right?
Okay.
So this you have to know, of course, and in all our handbooks, this is also described, both the Ranger handbooks and your guys and the European handbook, it's all described, the different doses there. And that is something that's difficult to learn by heart, but you've got to understand that there's a different dose, of course. Then you just look it up. But when we get back to pain treatment, then TCCC recommendations are very clear-cut. It says 10 to 20 milligrams IV, which in my experience is great. I would probably start with 10 milligrams of S-ketamine. It's a little bit more potent. And then I would just bump it up after 5 or 10 minutes. The good thing with IV, you get onset very quickly. You get effect very quickly. So you can also react very quickly. Bad thing, for example, IM morphine. The classic problems in hospitals is the nurse comes in and gives you 10 milligrams of IM morphine. It takes around 20, 30 minutes before it works properly, before you get peak effect. And then she's out doing something else, right? So if you don't have any effect, you maybe have to wait a couple of hours before she comes in again.
Right.
That is because they are not trained either to give drugs properly. When you give a drug, you have to look at effect. And if you can first expect effect after 20 minutes or 30 minutes, then you have to check it after 20, 30 minutes. If you give it IV, we know the effect is there in 1 or 2 minutes. If we haven't reached the effect we want, we can just repeat it, right?
Right. And I mean, that's a little bit easier said than done when like those are a long 1 or 2 minutes when somebody's in a lot of pain.
Oh, yeah.
But you have to have that, discipline. You have to have that patience. Look at your watch.
What you guys in the States don't really do, as far as I remember, you don't have something called ketamine labs.
That's true.
Where the guys, they receive a little bit of ketamine and just to see how it works on themselves. And of course, I've never done that. Well, we never do that in Europe. But and that's a very interesting thing too, because then the guys find out that 10 milligrams IV or then 10 milligrams IM, there's a difference. And they find out it's not dangerous. They don't hallucinate blue dragons. So that's something that is frowned upon by the officers, of course. But when we work in austere environments like we do, I think it's something one could consider. And I'm quite sure people are doing it here and there. But ISTC had big problems with it. They did a formal, official ketamine lab, and that was closed down very, very, very quickly by the German uppers, by the German command. Yeah. But I don't know why, because, Jesus, we're out fighting a battle. We have to know how to use our drugs.
Yeah.
So the easy way is to find your vet, have a good chat with your vet. Yeah. I think LTT, like you guys are doing in Bragg, is good because they get to really use the drugs, see the effect. But they probably have problems also when the pig is not sleeping properly.
Yep.
Right?
Yeah. There's big problems when that stuff happens. So, a medic out in the field, he's trying to do some analgesia. He overdoses. He gets them like right in the middle. And sometimes some of these recommended doses, especially when you're dealing with somebody whose hemodynamics are a bit soft, it's definitely possible. So what do I do if I end up landing in that middle zone and he is just, he's not reacting to you, he's reacting to whatever planet he's on? Like, what do I do? Do I just dose him again and then knock him all the way out? Or do I wait and let that stuff burn off?
Well, as I mentioned before, if I have a guy with emergence phenomenon like this, I would probably use a low dose Versed midazolam.
Okay.
A low dose, half a milligram, 1 milligram, no more than that, just to take the top off that. And then I would wait, because we know ketamine duration is short. It's 15, 20 minutes. So if you can handle it, wait. Don't panic, because then he will get down into a phase where he's well pain treated maybe, but does not have the adverse events. So I would wait a little bit, maybe give him a little bump of Versed, but not too much. Because I agree with you. The other thing is, of course, depending on his trauma, depending on what mechanism of transportation we're using. Is it a bumpy truck drive? Is it a smooth Piper, or is it a helicopter that shakes all over the place, or whatever? Depending on the trauma and the method of transportation, well, why not sedate him deeply? Right. Because we know sedation with ketamine, as long as you're traveling with him, of course. I wouldn't deeply sedate him if he's just going to go with a Casevac somewhere. Or a Medivac, where you don't know the guys and the guys don't know ketamine. That's something you would have to consider in your mission planning, right? Yeah, of course. Yeah, you're not necessarily helping the other medic out by snowing him and then throwing him on the helicopter and the truck. No, he's probably got his algorithms also, right? So if you deliver a patient that's deeply snowed, maybe you're not helping him at all. I agree. Yeah. Absolutely. But if we do have these adverse events, I would probably just not panic. I would just restrain him, give him a little bit of Versed, and then wait the 10 minutes. Yeah. Because I've definitely seen it where guys, like, they'll come up with their plan, right? Now that I've kind of shown them, like, you're not doing this correctly, you need to have a plan. They're like, okay, my plan is to, give this guy pain control. For whatever reason, they overshoot. He gets a little panicky. He starts grabbing at things, and they're like, "Oh, like that was wrong." Like, and then they just sedate him. If your plan was to provide pain control, you don't have to immediately shift your plan. You just have to have some patience. Recognize, okay, I made a mistake on accident, right? This is how we react to it. You don't necessarily have to. When you teach your clinic there, do you get them to draw up atropine, Versed? Is it ready to use, or do they just have it in their pack and they can take it out if they need it? Well, how do you teach it? So with the pigs, usually they have it. They don't necessarily draw it. I try to, and maybe it's not the right answer, but I try to get them like just slow, like. Stop panicking and like just doing stuff. Think about what you're going to do. Make a what's your initial plan? What's your initial dose? And we'll start going from there. Understand that, if something happens with this airway, you have the gear. Like I tried to teach them, like, respond to all your emergencies before they happen. So even all the way back in your mission planning and what you're packing in your bag, like, I teach them like the MISMAID acronym, so you have your monitoring, you have your suction, you have your airway things, you have your drugs and, whatever adjuncts you think you may need. All that planning is done long before you stepped off, so that when those things happen, you already know where it is. You already have a plan to use those things, and then you can just kind of engage. I don't necessarily have them. There's no difference here, Dennis. I'm sorry. Go ahead. Sorry, I'm interrupting you. Sorry. No, I said I don't necessarily have them draw it up, because once you draw it up, I don't want them wasting a dose. I don't want them wasting any kind of gear unless they have a plan for it. Like, I'm going to use it. Now I pull it out and do it. Okay, it's just I was just considering the didactics in it, and when we in the teaching situation ensure that everything is ready for adverse or side effects. Yes, absolutely. But, okay, that's just a way of thinking. Okay, but there's no real difference if they give morphine or they give an antibiotic or they with an allergic reaction, or they give some fluids that doesn't go into the vein but goes into the subcutaneous. I mean, these are all side effects, adverse effects, and the students there, of course, have to know this. They have to be trained on it, right?
Yes, absolutely. And
so
it happens.
There's no difference. There's no difference between ketamine and morphine and whatever we give them.
Nope.
Not in the principle of using it. No.
Right, and that's what I try to teach them. So the name of the class is pharmacology, but I don't talk about a drug until we're like halfway, 3/4 through the class, because I try to hammer home there's a technique to using any that works with any narcotic. These are the bad things that can happen. Let's be prepared for those things. This is how we monitor the patient and ping pong them down to an ultimate goal, which is, what effect do you want? You're giving them poison. Like, what do you want to get out of it?
One thing, we haven't really talked about the advantages of ketamine sedation is with the hemodynamic unstable patients, of course. That's where we really found interesting stuff. Another thing is asthma patients. If you have a severe asthma, they haven't talked very much about it because the clinical studies are a little bit weak on asthma. But in 2022, they made a big study looking at everything that's been out the last 10 years. And there's no doubt about it in their conclusion that ketamine is the drug of choice for refractory status asthmaticus.
Yeah.
So it's a very good sedation. If we are talking about kids, for example, the number of intubations and ventilations fall dramatically when you use ketamine as a sedative.
Yeah.
So that's something to remember. So hemodynamically hypovolemic patients. Ketamine is the drug of choice, no doubt about it. And that's why severe trauma, they all lose blood. We all know that. They've lost liters of blood. So, of course, until they get their blood transfusions, they are in a danger zone. So if you're starting snowing them with morphine or Penthrox or all the new stuff that's coming out, that is dangerous in comparison to ketamine.
Yeah.
So,
So, normally what I'll see giving ketamine, you'll see like a slight increase in the heart rate. Hopefully blood pressure comes with it, hopefully. But it's definitely, I haven't found it to be like the magic thing that will fix the situation. Blood will do that. But as far as helping kind of give you a plateau, or they don't crash quite as fast, using ketamine, that's definitely what I found, is it kind of puts a pause on it for just a moment while we're getting resuscitation rolling.
An interesting study from Southwestern, I think you've got a university called Southwestern.
Yes.
That has just come out also, is that they make a negative pressure study looking at the tolerance for hypovolemia, giving morphine or ketamine or another drug. And the tolerance for hypovolemia is higher giving ketamine and the other drug, whereas morphine tolerance to hypovolemia falls. And they're looking at a whole lot of cardiac things, right?
Yeah. I mean, if I understand it right, I think it makes sense, right? Morphine, you get that histamine response, they vasodilate, versus ketamine, at least in some patients anyway, kind of augments that sympathetic response.
Exactly. And there's the other thing, the big controversy was the ICP problem, the intracranial pressure problem. And that seems to be dead now. The first studies that came out were filled with problems because they were not controlling the CO2. So that's where the first rumors of that it would be detrimental using ketamine with head trauma came from. But they've gone away from that. One thing that has been maintained is intraocular pressure if that's high because of a globe trauma or a glaucoma. There are suggestions that you do not use ketamine there, but in our world, we won't be seeing this. We'll be seeing open global damages, and no, it's not the problem.
Yeah. But speaking of head trauma, sometimes seizures go with that, TBI. Have you heard, so I've had a few like ER docs say that they will use ketamine to help block or stop a seizure.
Yes.
Have you seen that?
But I've read status epilepticus, it's called in my country, right? Refractory seizures, yes, is treatable with ketamine.
Okay.
I would probably think that it's depending on what the trauma is. One thing is normal epilepsy. Another thing is epilepsy or epileptic seizures because of trauma. I don't know. I don't know where we'll go with that. But what we have is a head trauma with seizures, and ketamine is not contraindicated there.
Okay.
But if it works, I don't know.
Yeah. I mean, danger-wise, I can't really think of a danger. Like, I'm trying to use my benzodiazepines. They don't seem to be working. Maybe they worked earlier. They're not working now.
Yeah.
How far wrong can I go giving them a dose of ketamine?
Can't go that far wrong, no.
Yeah.
One thing we didn't talk about was that in old days, using ketamine, they suggested using an oropharyngeal airway to ensure free airways. We were discussing this when we had so many patients lined up, walking from patient to patient and not having eyes on totally all the time. We were placing oropharyngeal airways, and it was quite interesting. The patients were spitting them out during the wake-up phase. So then we knew they were waking up. That wasn't bad. They spit it out themselves. But of course, that's not really our world. But come on, sometimes we're overflowed with wounded patients. And if you are considering running multiple anesthesias and washouts at the same time, maybe you could consider, if you only have one set of eyes for 3 patients, using an oropharyngeal airway.
Yeah.
It's not, they don't struggle with it at all. Not while they're in deep sedation, but when they start waking up, they spit it out.
Yeah. Yeah, that's one thing I was wondering is because you still have all your muscle control. Would they essentially gag on it?
No, they don't.
Even while they're down.
No, not when they're deep, but of course during emergence.
Okay. I mean, is there any other tips or tricks with using ketamine that say I'm a brand new guy. I'm going out to a really bad place. I got a bunch of ketamine. I don't have lots of experience. What advice would you give me?
Well, ketamine anesthesia is probably the most common anesthesia in the world. And when you read articles, you're reading developing countries use ketamine. No, I mean, countries like India, it's the most common anesthetic in India is ketamine. So if you want to get experience when you're out in the world, why not visit a local clinic? Say hi to the guys. Say, let me see your anesthesias. Let me see how you do ketamine. If you have time for it, that would be a good idea. And get hands on there and then see how they do it. Because it is so common in these countries. It's the way of doing things.
Yeah.
And that's the way to learn it.
Yeah,
Right.
Definitely.
That's one thing.
Experience, hands-on experience is definitely the best way to get it done.
Yeah, I wouldn't have a problem with that at all. So just like all tropical medicines, if you're in an area with tropical medicines, you visit, of course, the local doctor, the local clinic, have a good chat with them, drink some tea, talk about his kids and his family, and then ask him what's happening in the area. Right. I remember down in Task Force 7 in Lashkar, when we had our local doctor, military doctor, and I had read a lot about malaria. in southern Afghanistan. He went over and said, have we got a problem here with malaria? And he looked at me and said, I've been here 30 or 40 years. I've never seen a malaria case. So, okay, oh, you can handle that as you want to, but that was an interesting thing, right?
Yep.
So you utilize the locals. And
Yep.
when we talk about ketamine, it's a good idea to do that too.
Yep, absolutely. Cool. Well, thank you, Pac. I really, really appreciate it.
Yeah, a rambling talk, Dennis, here and there and everywhere, but it was an enjoyable thing talking with you. Thank you.
No, I appreciate it. That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast. Out. That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.